Hi, this is Sophie. This is my presentation on Breaking Bad News for part 3, as it did not record on Zoom. This is the link to the WhatsApp group in which we discuss all of our cases. Please scan this link and join. This is what we're going to go through. We're going to go through types of Breaking Bad news stations, talk about getting marks, talking about how we get marks on a Breaking Bad news station, go through my template, and then we'll do some station practice. So sometimes Breaking Bad news stations can be obvious. They want you to tell a lady she's got cancer. They want you to tell a lady she's had a miscarriage. Sometimes they can be less obvious, discussing subfertility or discussing complications post-operatively. My tip is, if you are even a little bit suspicious that this might be, or this might count as Breaking Bad news, then make sure you're using a Breaking Bad news format. Make sure you're giving a warning shot. Make sure you're using plenty of pauses and showing lots of empathy. How do you get marks in a Breaking Bad news station? So there'll be an examiner, at least one. If it's just one, it's a clinical examiner. They're usually marking you on 4 domains, which will be 4 of one of these 5. So 5 domains: patient safety, information gathering, applied knowledge, communication with the patient, communication with the colleague. In Breaking Bad news, it's almost definitely going to be at least applied knowledge and communication with the patient, and then 2 others. And then the clinical examiner will mark you as either a pass, a borderline, or a fail in each of the domains that they're marking, and you'll get a total of out of 8. 2 if you pass the domain, 1 if you're borderline, 0 marks for the domain if you fail. So you can fail a domain and still pass the station overall. Now if you walk in and find there are 2 examiners and alongside the patient, you have won yourself a lay examiner. Lay examiners are members of the public. They don't have any obstetric and gynecological knowledge. They therefore cannot examine you on your applied knowledge, and they're likely to be examining you on these 3 domains. And they will therefore also score you as a pass, a borderline, a fail in those domains. And so your overall total, if there was a lay examiner, will be more than just the 8. So a lay examiner is a gift. You can double your marks without knowing much, because they're not marking you on your applied knowledge. So if you see 2 examiners, remember to really over-egg your empathy, your pauses. And then it's also worth mentioning asterisk points. These are the essential points in each domain. There's not always an asterisk point in a station, but the safest way to revise the exam is to assume there are, and to make sure that you've considered what the asterisk points would be for any station. Because if you don't get the asterisk point in that domain, you can't get more than a borderline in that domain. So for example, if there was a station in which you were prepping someone for emergency surgery for a ruptured ectopic, one of the asterisks in patient safety might be asking about whether they accept blood transfusions, because if you're whisking someone off for a surgery and they've got 4 litres of blood in their tummy, you didn't ask them, it turns out they're a Jehovah's Witness, that would be a major patient safety point. So if you failed to ask that, you could not pass the patient safety domain. You can still pass the station overall. So if we look at this classic Breaking Bad news station, so you are the ST5 gynae registrar on call, you've been asked to speak to Gina Graham in A&E. Gina is a 58-year-old woman admitted with abdominal pain. She had a CT abdomen and pelvis, which has shown a 7 cm complex left adnexal mass with ascites and widespread peritoneal lesions consistent with metastases, and her CO125 is 934. Your task is to take a focused history from Gina, explain the findings, outline an initial management plan, and answer any questions she may have. and this task assesses the following domains: information gathering, applied clinical knowledge, communication with the patient, and patient safety. So if I was tasked with this station, this is how I would go about answering it. So I know I'm being marked on 4 domains. I can only get marks in this station from talking about things in these 4 domains. So the domains are information gathering, communication, applied knowledge, and patient safety. I would write those down on my bit of paper, and I would then in each of those sections write the key things I need to say to get those points from that examiner. Information gathering is easy, that's just their past medical history. And I would put little asterisks around the things that I think could potentially be the asterisk pointers. So allergies, if she's had any major surgery, would obviously impact any surgery she could have in the future. And family history is a key one for the cancer stations, because they love BRCA, they love Lynch syndrome, and if this woman has a significant family history, I'd obviously need to offer her genetic testing and genetic counselling, and that would be a key point. Another thing that's worth mentioning is whether or not you should be doing this information gathering before you've broken bad news or after you've broken bad news. Me personally, I prefer to do it after. You've got a woman who's very anxious, she's aware something's going on, she's aware that this is not normal for someone from a different speciality to be coming along and discussing the scan. She's probably cottoned on that she's about to have something bad told to her, and she doesn't want to sit and answer questions about her past obstetric history and her smears. She wants you to get to it and tell her what's going on. So I think in most of these situations, especially if you've got someone who's had a scan, in like an obstetric patient had a scan with an IUD and they're waiting for someone to explain, they know something's up, they don't want to be sitting talking about their past obstetric history, they want to know what's going on with this scan, and they want you to tell them sooner rather than later. So my recommendation is to not do this first, but to do it after you've broken bad news. We'll come up to this, I'll discuss this more in more detail. So communication, how am I going to get my communication points? I'm going to make sure I'm writing in a breaking bad, I'm speaking in a breaking bad news format, I'm giving her a warning shot, I'm offering if she wants someone to come and be with her whilst I'm talking, providing lots of empathy. I'm breaking the information up into small sections and then checking she's understood, so chunking and checking. I'm giving her plenty of time to ask questions. I'm asking if she wants me to speak to her family. I'm making sure I'm giving her all the contact details of the specialist nurses and info leaflets. In applied knowledge, I need to make sure that I'm getting these points. I need to show that I understand how we manage stage 3 for ovarian cancer. So we need to complete the staging process. She needs some sort of chest imaging. She'll get referred to the MDT. Her operation will happen at a cancer centre. It'll involve some sort of major surgery, and she'll also need chemotherapy. My patient safety marks. Remember to always be showing empathy, checking about her allergies and a blood transfusion, her family history. The college loves VTE risk at the minute, so I want to make it obvious that I'm checking she's on tinzaparin, and I would always want to involve my consultant. If there's a lay examiner, you're going to get double in these, so you really have to knuckle down and make sure you're getting this right. How do I approach breaking bad news? Again, this is my technique. There are many different ways. The key is to get one and become accustomed to it to the point it becomes second nature, so you don't need to think about it. You can think about other things. I introduce myself. I establish why I'm here. I've been asked to come and explain a scan result. If your consultant is busy, and they should be here, it's always important to mention this here. I'm here, my consultant's in theatre, but they're going to come and talk to you as soon as they're free. Establish what they know already. This also acts as a little bit of a warning shot. So what's happened that's led you to come into hospital recently? What images have they had done so far? What investigations have been done so far? What results do you know about? Then give your warning shot. So the results I'm about to tell you are not normal. They aren't good results. I have bad news to tell you. Pick whatever your warning shot is and keep it. Use it again and again. So again, you're not having to stumble over it. You know exactly what you're going to say before you've said it. Once you've given the warning shot, you ask them if they want someone to come in with them. They're going to say no. The college can't afford extra actors. Then you want to give them a short, snappy diagnosis. Don't go into too much detail here. The rip the plaster off bit needs to be, I'm very sorry, the scan has shown a lesion in your pelvis that is very suspicious of cancer. Pause. Let them react to it. Once they've had their reaction, then go on to give a bit more detail. So yes, there's a 7 centimetre complex looking mass in the pelvis. There's also some fluid in the pelvis and some lesions inside the liver, which are suspicious for metastases, which is where the cancer spreads. Again, pause again. That's a lot of difficult information. If you've got any questions, anything immediately you want to say or ask. Now, because you've broken bad news first, you haven't done the information gathering. You need to be very careful not to get derailed. They're going to ask all sorts of difficult questions right now. They're going to be wailing, they're going to be crying. So it's important to get you both back on track here. These are really understandable questions. I can see that you're really upset. Okay, in order for us to make sure we get the best care for you, I need to know a little bit more information about you before we move on, before we answer those questions. Okay, once I've got that information from you, we'll then go on, tell you what's going to happen next, and answer any tricky questions. Okay, all right. Then go on to your history. So, have you had children? Have you had ASMEs up to date? Any other medical problems? Blah 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 blah. You need to get that bit really, really slick and fast. You need to be doing that in 2-3 minutes tops. Close questions. Have you got this? Have you got this? Any history of this? Yes, no questions. Once that's done, go, okay, thank you for that. So back to that question you asked me. Well, and then give the answer. And now I'd like to tell you a bit more about what we're going to do next, if that's okay. First I'll talk about what happens right now, then what happens the next couple of days, and then what's going to happen more long term. If you're talking about, they're talking to them about a complication they've had during a surgery or anything where something's gone wrong, remember your 4 Ds, which is your duty of candor, your debrief, your datix, and then document it. And obviously then you want to be talking about any further investigations if they're getting referred to any specialists and any specialist treatment that's going to happen after that. Okay, so with regards to this station, I'm going to just quickly talk you through specifically what I would say for all of these points. So, hi, my name is Sophie. I'm the gynae reg on call. Can you confirm your name and date of birth? And is it okay if I call you Gina? So, the doctors looking after you in A&E have asked me to come and have a chat with you about your recent scan. So I just wanted to know a little bit about what brought you into hospital, if that's okay. What investigations have you had so far? And have the doctors explained any of the results to you yet? Is there anything in particular that you're worried about? So Gina, unfortunately the scan has found something concerning. Would you like anyone here while I explain the findings? So Gina, the scan has shown a suspicious looking mass in your pelvis that it's likely to be a cancer. I'm so sorry to be bringing you such awful news, and I'm sure you must be feeling really shocked right now. There are some more things that I need to explain. Let me know when you're ready to hear it. So as I mentioned, there's a mass in the pelvis, which is most likely an ovarian cancer given its location and the high levels of CA125, which is a blood test that we do looking at the ovary. But the only way to be sure is to get a sample from the cancer and look at the tissue under a microscope to know for sure. There are some lesions elsewhere in the pelvis and in the liver, which likely means the cancer has spread, and these are what we call metastases, which are cancer deposits that have spread separate to the original mass. I know that's a lot of really difficult information that I've just given you, and you must have so many questions. Are there any immediate ones that come to mind? Remember, don't get derailed at this point. You still haven't taken any history yet, so if there's any quick questions you can answer them. But my preference is to set the agenda now, which obviously the agenda would include answering her questions, and this helps reset my brain and the patient's brain. It gets us back on track to what's going to be happening and where we're going with the station. It also has a benefit of, if we're running out of time, If I set the agenda now and say, right, what we're going to do now is we're going to talk about the investigations that are going to happen next, and then the surgery that's going to happen, and where we're going to refer you to after this, kind of shows the examiner at least what I intended to do, even if I don't fully have time to do it. So say she's asked, I don't know, gosh, how am I going to tell my family? How long have I got to live? You could then go on. So that's all a very understandable question. But what I'd like to do, if it's all right with you, before I answer it, I'd like to ask you a few quick questions about you and your health to make sure that I'm not missing anything important that might help me answer those questions. Then I'm going to explain to you what's going to happen next, what investigations we're going to do, and which specialist I'm then going to refer you to in order to tackle this disease as best we can. Does that sound okay? And they will usually go, yes, fine, doctor. So then go on to your information gathering. That's just your very standard gynae history. Make sure you're remembering to ask about family history, social history, smoking, surgical things, all your usual stuff. Don't forget any of it, or you won't get your full marks for information gathering. Then once you've done that, okay, you can go back in. Okay, so in the first instance, we need to get a scan of your chest to check there's any signs of disease there. Then we're going to refer your case to a specialist team of consultants who work in gynecology, in cancer care, in radiology, that's looking at imaging, and surgery, alongside specialist nurses and other healthcare professionals. They're called the MDT, the multidisciplinary team, and their job is to look at all the information, the images, the history, and using all their expertise, they'll work out the best course of action for you. Okay? So it's important this needs to happen before we jump into anything. This is likely to involve some sort of major surgery to remove all of the diseased tissue, and chemotherapy, which can be given either, and then chemotherapy, which can be either given before surgery, which we call neoadjuvant, or after surgery, adjuvant. Sometimes we can even give it during the surgery. And as I said, that MDT of people will decide the best course of action for you with regards to what sort of surgery, and then what sort of chemotherapy. Some types of disease are so far advanced that actually surgery isn't appropriate, in which case we'd need to focus more on chemotherapy. Okay, if you do need surgery, the surgery will be at a unit that specialises in complex cancer surgery. I know that the idea of waiting for this meeting of specialists, the MDT meeting, before we can start anything may seem like an unnecessary delay, which may seem a bit scary, but it's important that the right team of people make the best plan in order to ensure that we can get the best treatment for you. Does that make sense? Do you have any other questions? Okay, in which case they might be asking about how long have they got, why has it happened, why was it not picked up sooner? I'm going to arrange for our cancer specialist nurse to come and see you today. Oh, sorry, I was saying, so I've got a slide where I talk about how we answer these questions. Okay, but once we're happy that the questions have been answered, we then go into what happens next. So I'm going to arrange for our cancer specialist nurse to come and see you today, and make sure you have her details too in case you have any questions later once I've left. I'm also going to discuss your case with my consultant, so they're aware too of what's going on. If it's alright with you, I'm going to have a quick look at your drug chart to ensure you're on blood thinning injections, because you've got quite a high risk of getting a blood clot. I'm also going to make sure you've got regular painkillers. Okay, can I get anything painkiller wise for you now? And is there anything else I can help with immediately? So when they ask the tricky questions, it is important that we answer them. So probably going to ask, am I going to die? How long have I got left? This is the hardest one to ask, and I do my best not to answer it if I can. So I understand this is one of your biggest concerns right now. I wish I could give you an answer. At the moment though, we need some more information about the disease to be able to have the whole picture before we can answer that. I'd hate to cause you even more stress and anxiety than you already have right now by giving you incorrect information. Okay? Would you like me to tell you about the next steps and how we go about getting that information so that we can answer that question? How did this get missed? Why was it left so long? If it's got someone where we've missed this diagnosis, it's more about being sorry. So I'm so sorry this is happening to you. I don't have all the information available to know what's gone on in the past and if anything could or should have been done differently. What I can do though is make sure that we investigate it, and if we do find that there has been opportunities missed or mistakes, that we have a process by which we report these incidents formally, and that will ensure there's a full investigation to make sure that we learn from any errors and reduce the likelihood of it happening again. We'll obviously keep you informed throughout the whole process of this. Will I lose my hair? Not everyone who has chemotherapy loses their hair. I understand how important hair is to a woman's identity though. We have some very specialist chemotherapy nurses who'll be able to direct you to all the best resources in terms of reducing the hair loss and managing it. Am I going to be in pain? We'll do everything we can to manage your symptoms and have specialist teams who make it their priority to manage cancer pain, and you'll have all of their details before you go home. How will I tell my family? It can be so daunting discussing cancer with family, especially children. We have some good written resources to hand, and the Cancer UK website also has some useful tools. Our cancer specialist nurses will be also happy to help and support you with that. And you could also invite your family in, and I'll be happy to help you have that conversation with them if you'd like. This is a quick revision slide I've got, just looking at ovarian cancer, and on the website there's also I've got slides like this for all the main cancers, so ovary, cervix, vulva, what am I missing? Endometrial cancer, just the main key summaries for part 3, because you don't really need much more information than this. That's just in general resources on the website. But for ovary, key thing to remember is that your staging, your chest imaging is actually a chest x-ray. Surgery is likely to be hysterectomy, bilateral salpingoophorectomy, omentectomy and washings. Sometimes it's actually nice to say that that's what the surgery is likely to be. So we'll take out your womb, we'll take out your tubes and ovaries, a small sample from the omentum, and then we'll do some washings, which is putting some water into the tummy and sucking it back out again to look for any cancer cells. Okay, we might want to take some lymph node out, and if there's any visible surgery, we'll remove that too. Explaining what about the chemotherapy, which might be before, during or after. I think it's unlikely they're going to want to know much about staging, but this is the key information. They like a bots. Make sure you know about your bots. And that if it's mucinous, we'll take the appendix out. And that for bots, we'd still recommend a hysterectomy BSO unless she wants to still have a baby, in which case we'd offer a unilateral salpingoophorectomy. Follow-up for a bots is 10 years. I've made a list of the possible stations that might come up. So gynae, your cancers, your precancerous would class as breaking bad news as well. Remember, cervical cancer, anything more than stage 1B3, you don't actually offer surgery, it's just chemo radio. I think people get unstuck by that in exams, saying, oh, we're going to do a hysterectomy. But actually for cervical cancer, once you've got any sort of spread anywhere, or any significant visible disease, it's actually chemo radio. Cervical cancer in pregnancy, obviously discussing hysterectomies in women who are pregnant. Complications post-op, so someone who's ended up with hysterectomy, oophorectomy, bilateral appendectomies, stoma formation. So explaining that the complication has happened would be breaking bad news, and then remember what happens next, framing it in terms of what happens immediately, what happens in the next couple of days, what happens in the next weeks to months, and making sure that you do your duty of candour, explaining what's gone wrong and what's going to happen. Your DATIX, that's your second D, which is the incident reporting. Debriefing the patient, so explaining everything and then documenting it. Then your 4Ds. They're like ovarian or testicular failure, so your POIs. Obviously remember that anyone with a miscarriage, an ectopic pregnancy, a molar pregnancy, that's all breaking bad news. And then your unexpected diagnosis of XY, such as AIS or Sawyer's, would also be breaking bad news. And obstetrics, they like IUDs, counselling women who come in pregnant with conditions in which pregnancy is contraindicated, so recommending TOPs. debriefs after complications in surgery, then your fetal medicine one, so counselling people who have lethal conditions or significant abnormalities. And then I do believe the rest of the recording is now on Zoom, and that will be uploaded separately. But our stations, I'll just look for you for anyone who is here. How we approach it. Station 2. I'll go back so you can actually read it. No, I can't now. These have all been recorded separately on Zoom. If you look on the second link, we go through these in more depth. But I'm putting it through. And that is the some revision on POI. Thank you very much.